introduce our next speaker is Dr. Nader Ali. Dr. Ali is a cardiology specialist who has been practicing for the last 29 years. He is the chairman of the Department of Cardiology at Clear Lake Regional Medical Center. Before working as a cardiologist, Dr. Ali served as an assistant professor of medicine for 8 years at Baylor College of Medicine in Houston, where he also received his medical training. Dr. Ali graduated in 1984 from All India Institute of Medical Sciences. His focus is on managing heart disease, obesity, metabolic syndrome, and diabetes. He specializes in cardiology and interventional cardiology and has championed many aspects of the science and practice of the low carbohydrate lifestyle. Every month, Dr. Ali organizes a nutritional seminar in the CFC auditorium of the Clear Lake Hospital. Please help me welcome Dr. Ali.
Thank you. So thank you for the opportunity to have me here. I'm going to talk a little bit about cholesterol, about statins, about LDL. So by a show of hands, how many of you think of LDL as the bad cholesterol? You guys are healthcare workers. So just a couple of hands, not sure. Well, I'm going to ask the same question at the end of the talk because I think that LDL requires a little bit of redemption, a little bit of respect that we have not given it. And you would think very strange that a cardiologist is talking to you about LDL as something that has biologic function. Because if I learned about this in medical school, that LDL has a biologic function, I missed that class or skipped it. I have no disclosures, but I should add that we are joining IDM with Jason Fung, so some disclosures may come down the road. So to kind of give you an idea of what cholesterol is a fatty substance, just like triglycerides. And if you take a beaker of water and put oil into it, it will not mix. And similarly, our blood is watery. So if you put fat or cholesterol into it, it's not going to mix. So our body has created this ingenious system in which it packages the cholesterol and triglycerides into a lipoprotein molecule. So the lipoprotein molecule has an outer layer of phospholipid that makes it dissolve. It has some key identifying proteins that make it do a function. So that is a lipoprotein, and lipoproteins, and several of them are listed out here along with some of the things that regulate the lipoproteins like PCSK9 and LDL receptor. And these lipoproteins have evolved through millions of years of evolutionary engineering, and they have a biologic function. So I thought one slide would be enough to show what LDL does. And common in all of this is LDL. So LDL is crucially involved in host defense. Who would have thought that LDL will fight bacteria and viruses? That will dampen inflammation that happens as a result of bacterial products. When we think about reverse cholesterol transport, we always think about the HDL. But LDL is a crucial player in reverse cholesterol transport back to the liver, because an important thing for us to realize is that cholesterol is not a metabolic fuel. Dr. Volek talked about fats and triglycerides that we can burn, sugar that we can burn. Cholesterol we can't burn, we have to eliminate it in bile. When our cells get damaged, they need cholesterol for cell repair because every membrane in our cell, every membrane of every cell in our body needs cholesterol for proper function. Now, we have talked a lot about diabetes. Would it surprise you to know that cholesterol in the membrane is very important for insulin receptor functioning, that several pathways in cholesterol synthesis are involved in making receptors be properly processed so that cell signaling can occur. Now, there was a fantastic talk on testosterone, but it's important to realize that the human testis and ovaries cannot make cholesterol of its own. Cholesterol is the substrate that it uses to make testosterone and estrogens. And the primary lipoprotein that supplies the cholesterol to the testis is LDL. Now moving on, they have triglycerides in them, so they are energy delivery vehicles. So I started out with one slide saying that was enough. This is the second slide, and I thought I still couldn't finish all the important biologic roles. LDL is involved in muscle function because it carries CoQ10. CoQ10 is an important part of our mitochondria. And finally, LDL is involved in prevention of vascular calcification, and I'll demonstrate that to you in a little bit. So the question one should ask is that, should I tamper with lipoproteins in general or LDL in particular when millions of years of evolution has bestowed it with host defense, modulation of inflammation, preventing calcification of the blood vessels, receptor functioning, cell signaling that helps us think, cell repair, muscle function, membrane integrity, energy delivery. And by God, this list is not complete, and I can add a couple more pages here. But as it so happens, we want to tamper with it. But if we go back, nature has already done this for us. There is a condition which is called A-beta-lipoproteinemia. So children are born with this genetic disorder in which LDL is absent. They don't have any LDL. It's between 0 and 50. So in this condition, the LDL and some of the related lipoproteins are absent. So you would expect that these people should live forever, right? But what happens is that they get recurrent infections because LDL is involved in host defense. They get blindness. The reason for blindness is because the LDL molecule carries fat-soluble vitamins, vitamin E and vitamin A. They get neurologic dysfunction. They cannot walk well because myelination of your nerve cells is dependent on cholesterol. So instead of living, there is a failure to thrive, and most of them are dead by their third or fourth decade, and very few survive into their fifth decade. But instead of learning from nature, we like to make the mistakes on our own, and so we started this use of the statins and a new drug which is called PCSK9 inhibitors. So how many of you know about the new drugs by a show of hands? The Repatha, the Praluent? So just a few, or one rather. Cholesterol is extremely important for the body. If you ate no cholesterol, if you went on a completely vegan diet and had not a single molecule of cholesterol in you that you were ingesting, your body will make about 1.5 grams of cholesterol per day. So 1,500 milligrams. And it has an amazing enzymatic machinery. About 30 different enzymes are present. And when you use a cholesterol drug, blocking drug, the statin, you block the cholesterol production very high up in the synthetic pathway. So what happens? As you are making cholesterol, there is an isopentenyl molecule that the cholesterol pathway makes that makes the production of selenoproteins. So there's a lot of talk about pleiotropic effects of statins. How many of you have heard about pleiotropic effects of statins? Like they do multiple things rather than just reduce LDL cholesterol. So what I'd like to tell you is that there are negative pleiotropic effects because This is an enzyme that reduces antioxidant damage. It prevents free radical injury, and the production of that is reduced when you use statins. It also converts vitamin K to K2, which is important in prevention of calcification of the blood vessels of our body. It's also important in CoQ10. CoQ10 is coming from the same cholesterol pathway, and it's important for our muscle function. Dolicol, as I'll shortly show you, is important in processing our insulin receptor so that we don't get insulin resistance. And finally, cholesterol is very important, as we will see that our membranes that are cholesterol rich, they're called lipid rafts, and that's where the receptors sit. So I give you a lot of biochemical information, and it's important to be redundant. It's important to restate that. Among the intermediates of the cholesterol synthetic pathway, the isopentenyl produces enzymes that reduce oxidative stress, free radical stress. It prevents vascular calcification by converting K1 to K2. The CoQ10 helps with function of the mitochondria, as we will see shortly. The dolicol for processing the insulin receptor, and the cholesterol so that the receptors sit properly on the cell membrane. So this is a study in which they studied membranes that were cholesterol replete. So what that means is that they had enough cholesterol, and these are the lipid rafts that are cholesterol rich. The receptor is sitting properly, it's properly oriented. Another cholesterol-rich domain is the caveolae, which are basically invaginations in which the receptors are also properly oriented so that receptor function can happen. When you cholesterol deplete the membrane, the lipid rafts are gone, the receptors are in disarray, and the caveolae are absent. Now we talked about dolicol as a byproduct of cholesterol synthetic pathway. And dolicol takes the protein manufacturing machinery in our body. The ribosomes make protein. So as the protein is being made, and in this case is the insulin receptor, dolicol is important in attaching a sugar residue to that. So when it attaches a sugar residue, it gives the proper structure to the receptor. So far I was trying to focus on the effect of depleting cholesterol through statins on insulin receptor. And these are the three pathways, these are the three areas in which it will affect it. The lipid rafts, which is the cholesterol-rich domain, let the receptor sit properly. The dolicol attaches a sugar residue. And when the insulin comes and attaches to the insulin receptor, it activates a series of chemical changes that opens up a pore, which is called GLUT4, through which the glucose enters the cell. The proper positioning of the GLUT4 is also dependent on a cholesterol intermediate, which is prenyl or isopentenyl intermediates. So that's all biochemical information. Before I take you to the clinical side of things, I should tell you why this may be so. So this is a women's health initiative. They were looking at the incidence of diabetes in the women that were using statins in a postmenopausal state. About 10,000 women were on statins, 140,000 were not. The women that were on statins, the incidence of diabetes was 9.9% versus 6.4%. There was a 3.4% reduction in the incidence of diabetes. Now, if you were a Hispanic in that population, it was not 3.5% more, it was 5% more. If you were of Indian origin like me, it was not 3.5%, it was 7%. A lot of heavy hitting about the mitochondria was done by other people, but basically mitochondria are the engines of our cells. they do a series of chemical reactions. CoQ10, which is a cholesterol byproduct, is involved in that, and the end part of going through the electron transport chain of the mitochondria is generation of ATP. ATPs are energy currency. We said that CoQ10 comes from the same cholesterol pathway, and the way I think about it is like this. CoQ10 is like the spark plug for our muscles. If an engine is without a spark plug, it cannot burn fuel. If a muscle is deprived of CoQ10, and it will be if you give them statins, you are not able to burn fuel. So is there any evidence that this is the case? So this is a study that was done by a fellow Texan, and what he did is that he took 10 people who were on a statin, and he compared them with 9 well-matched controls, and he monitored them with muscle biopsies and with blood tests. So this blue line is the control group. So compared to the control group, the group that were on statins had higher blood pressures, had higher sugars, had lower amounts of CoQ10 in their muscles on muscle biopsy. They had lower levels of oxidation prevention enzymes, the glutathione peroxidase. They were less able to generate ATP, and they had more evidence of insulin resistance. So the same group did a study in about 328 patients coming to their clinic for the first time. So these 328 patients were on statins. They had come for the first time. And of these, 50 patients were identified who had statin-induced symptoms of either myopathy, memory loss, or tingling and numbness, which is called peripheral neuropathy. Now, he stopped the statins, and he measured it 1 year later, and he found that there was a substantial improvement in muscle discomfort, memory improved, peripheral neuropathy improved. In 28 of these 50 patients, he was measuring heart muscle function with an echocardiogram. So in these 28, the heart muscle function while on statins was reduced. When the echocardiogram was repeated 1 year later, about 14% had an improvement in their heart muscle function as measured by ejection fraction. There were a few that were unchanged, about 35%, but not all improved. So it's possible that if you have statin-induced muscle damage, and heart is a muscle, it may not be completely reversible. So moving along the same pathway, the industry got a hold of some of these studies, and they said, this is going to be very damaging for us, and what we should do is to show that by using statins, you're going to reduce heart failure mortality. So if you take a person with congestive heart failure, generally, the worse their congestive heart failure is, the lower their cholesterol will be. So statins will be used only in people with high cholesterol and not in someone with low cholesterol. So this is an unfair comparison. So what I did was to see how many people were not on statins, and whether the statins were used less than 25% of the time, 25 to 75% of the time, and greater than 75% of the time. The reason I did it that way is because if statins are beneficial, the more statins you use, the lower your mortality should be, and the less statins you use, the higher your mortality. But the exact opposite was found. If you're using statins at a higher percentage of time, all-cause mortality, stroke mortality, and coronary disease mortality was higher the more statins that you were using. This is a Japanese study, the Biologic trial, and Japan came out with this argument that anybody with a cholesterol over 220 should be given a statin. So 41,000 patients were given statins because they had cholesterol greater than 220. And here are the cholesterol levels. They are decreasing here because of treatment. And as the cholesterol levels are decreasing, you should see a reduction in all-cause mortality. But the Japanese people found the exact opposite. As the cholesterol went down with the use of statins, not only all-cause mortality went up, but cancers went up, strokes went up, and even heart disease went up to a slight degree. Now here is the same study in which cholesterol levels are plotted from low to high. The lower your cholesterol, the higher the chances of being a diabetic. So you're giving a cholesterol reducing medicine for benefit, but the lower the cholesterol, the higher the diabetes, and higher the cholesterol, the lower the chances of becoming a diabetic. Going to the pleiotropic effects of statins, they say we use statins not just to lower LDL but because they have so many anti-inflammatory properties. But here I'm showing you the exact opposite. In the cholesterol pathway, you make prenyl intermediates. These prenyl intermediates take the protein manufacturing machinery and they create certain selenoproteins, which is called glutathione peroxidase. This is a ripoff from Gary Fettke. This is his inflammation model. And what you see is that glutathione peroxidase reduces oxidative injury. So when you block the production of prenyl intermediates, you would reduce glutathione. You also reduce certain DNA repair enzymes through the same pathway. So when you are increasing oxidative injury, when you are reducing DNA repair enzymes, you should increase cancer risk. So here is a study in Danes, 40 years and older with cancer, and they are evaluating statin use and cancer-related mortality. So they're saying that statins reduce the risks of cancer-related mortality, which is an amazing claim to make. And again, it is a very fallacious argument because you would use statins only in people with high cholesterol. If you had cancer and you had high cholesterol, I would say that the chances of you dying is less. So I did the same thing here also. And in this, I'm seeing whether a lower dose of statin was used, a middle dose, or a higher dose. If statins are beneficial in cancer, the higher the dose, the lower the chances of dying and the lower the risks of cancer should be present. Exact opposite. The higher the dose of statins, the greater the risks of cardiovascular mortality and the greater the risks of cancer mortality in the study when you evaluate the data that way. Elderly people are more at risks of getting cancer. So there is a PROSPER study with pravastatin, about 6,000 patients, 3,000 in each group, 3.2-year follow-up, a robust reduction in cholesterol. What happens? The pravastatin group has a significantly higher risks of getting cancers than the control group in this older population. Same thing with skin cancer. The skin cancer was higher in a study with simvastatin, the 4S and the heart protection study compared to the placebo group. Now, how many of you know about calcium scoring of the coronary arteries? So a few of them. So you would think that if you reduce cholesterol with statins, that you should reduce the chances of getting vascular calcification, especially in the blood vessels of the heart. But I showed you that through the cholesterol pathway, the prenyl intermediates convert vitamin K to K2, and K2 activates a protein that puts calcium in the bones and prevents calcification of the blood vessels of the heart and the rest of the body. So here is a blood vessel of the heart that's showing coronary calcification, and I want to show you data that shows that using statins increases coronary calcification. So this is a VA study in diabetic patients. At baseline, the patients on statins had a little higher coronary calcification than the group that was not using statins, but 4.6 years later at follow-up, the increase in calcification was much greater in the statin group, and the progression of calcification was much greater in the statin group compared to the placebo group that were not receiving statins. So for the sake of time, I want to, it's a little bit of lag after the lunch, although I saw that most of you had a ketogenic diet, so you should not see the glucose-induced slump. So if you focus on this side of the slide, these are cell culture studies. So they took vascular smooth muscle cells that make the lining of a blood vessel wall in a culture dish, and they added increasing amounts of cholesterol-reducing medicine. And as the cholesterol-reducing medicine increased, the amount of calcification of these vessels increased. So I don't know how many of you have heard or know, but when this information came out that statins increase coronary calcification, the argument was that it is leading to plaque stabilization. So in other words, the plaques are getting calcified, they're not likely to rupture, they're not going to cause a heart attack. So it's easy for somebody to make that claim because there are all kinds of paradoxes in the cholesterol hypothesis. But this study should debunk that. Because when you looked at the cells, this is treated with a blood pressure medicine, but these are the cells that are treated with the statin. You can see that these cells are dying. So how do you come with plaque stabilization when the statins are creating cell death in cell cultures? So at this point, I have an animation slide, and I just wanted to keep you guys awake. So this is a cell membrane, and as our cell membrane gets damaged, the cholesterol in the cell membrane gets picked up by the HDL. The HDL, which is discoid in form, becomes spherical, and to transport that cholesterol back to the liver, it gives it to the LDL, and the LDL then subsequently sends it to the liver. So I think here is a little animation of that. The cholesterol is being picked up, it goes to the HDL gives it to the LDL then moves to the liver, and the liver picks it up and recycles the cholesterol and recycles the proteins. So here you are seeing that cholesterol is being recycled. So they said, hey, why don't we do a thing in which we prevent the transfer of cholesterol from HDL to LDL? So what will happen in that situation? Your HDL will go up. How many of you think about HDL as the good cholesterol? It's all of you, right? You guys are healthcare workers. So if you prevent the transfer of cholesterol from HDL to LDL, your HDL goes up, your LDL comes down, a cardiologist, an endocrinologist would salivate over that, a family physician would salivate over that and say, hey, your chances of having heart disease is very low, your bad cholesterol is low, your good cholesterol is very high. So in this 15,000 patient study, you can see that the good cholesterol is high, the bad cholesterol is low in the treatment group, and in the control group, the good cholesterol is low and the bad cholesterol is high. So what happened in this 15,000 patient study with a perfect cholesterol? What happened is that there was more mortality in the group that was treated this way. There were more cancer deaths, more hospitalizations for heart failure, more infections, and more stroke compared to the control group. So we were talking with Dr. Small about the power of one, and I think he left, but I want every healthcare worker and every physician to know how a clinical trial is done. So if you look at a clinical trial, the pharma is at the center, they pay the clinical site, they pay the site investigator, they pay a team of experts that the site investigator reports to, they pay the data safety and monitoring company or the group of experts who look at the data and say, hey, is this drug safe or no? They have a team of biostatisticians and ghostwriters that they pay. And according to the new regulations, a substantial portion of the FDA's budget comes from the pharmaceutical industry for new drug approval. And there is a revolving door between these two. In addition, when a trial is published in a medical journal, there are reprints that are made, and about 60% of the revenue of medical journal comes from the pharmaceutical companies. American Heart, American College of Cardiology, I don't know if any of you have gone to their big national functions. About 70% of their budget depends on the pharmaceutical industry sponsoring their functions. So where are the checks and balances in a clinical trial? The only thing that happens in a situation like this is that the patient suffers because there is nobody looking out for the patient, and science suffers. So now you may ask, there is so much information on cholesterol drugs that statins are beneficial, they are in the guidelines. What is that information? So what I have pointed out to you is that this is the best clinical study. So far, there has been no study that has been done that has been better than this study in showing benefit of cholesterol-reducing medicine, and this is called the Fourier Trial, and that's why I chose it. So when they were treated with simvastatin over a 5.4-year period, there was a 0.6% reduction in all-cause mortality per year. So treatment with this drug reduced the risks of dying by 0.6% per year. Translated into layman's term, if you treated 100 people for 1 year, you would prevent half a person from dying. So it would have been pretty honest for the company to report 0.6%, but what they reported is that there was a 42% reduction in the chances of dying from using this drug. So where did they get that 42% from? So I just want, although you guys are healthcare workers, this is a very illustrative example. I've stolen the slide from Dr. Malcolm Kendrick, and it says how to use statistics as mass disinformation. And I will pose you a simple problem, and that is that for the Texas Lotto, let's say I say your chances of winning the Lotto is 1 in 15 million, and I tell you, I can increase your chances of winning by 50%. By 50%. How much is that realistically? So you go from 1 in 15 million to 1.5 in 15 million. So that's a 50% increase in relative terms. In absolute terms, it is 0.6 zeros followed by a 3. So if I were a drug company, I would show myself like this, that I am a lottery expert, and if you want to be a millionaire, please send me $50, because this is no con trick. I am going to make you a guaranteed winner. On the other hand, if I wanted to be honest, this is how I would portray myself. The pathetic, desperate, lonely, rather hard up Dr. Ali can very slightly increase your chances by so much, and don't waste your money on me. So the truth is that whenever we talk about a clinical trial, we should never talk about relative risk reduction. We should always talk about absolute risk reduction, and then you will realize how underwhelming, how minimal the changes in chronic diseases is with medical treatment. So this is a daunting slide, I agree, but I spent a lot of time preparing it, and when I walk you through it, it will be fairly straightforward. So this is 1994 here, this is 2017 here, there are different clinical trials. Out here is showing you the reduction in bad cholesterol, which is called the LDL, and I don't know if the light is preventing you from seeing it, but in the beginning it was about 25%, over 5 years it was 3.3% reduction in all-cause mortality. But as time has gone by, a few different things happened. How many of you guys heard about the Biologic trial? So the Biologic trial was one in which Merck manipulated data. They hid information from the publication of the study. They put pressure on an FDA employee not to report negative information so that they could sell Vioxx. When all of this came out, about 88,000 patients had died, and 88,000 patients had had a heart attack, and about 40,000 died, and Merck paid $5 billion in damage, and that was around 2003, 2004 timeframe. And that's when new clinical trial guidelines came out, which said that to a company, that if you do a clinical trial, you have to publish it, and we are going to scrutinize you a little bit more. So prior to 2004, a company could do 10 clinical trials, suppress the 9 that didn't show benefit, and show the 1 that showed benefit. So as time has gone by, you can see that the degree of reduction of LDL cholesterol has increased. So you would expect, hey, I went from 25% reduction to 50% reduction here, nearly 60% reduction here, I should have a greater impact in all-cause mortality. So in Jupiter trial done in primary prevention, the all-cause mortality reduction was 0.5%. In the Fourier trial, there was actually an increase in that. Now, since many of you are not using PCSK9 inhibitors, and it's getting a little late in the day, I'll skip through the mechanisms of what PCSK9 does. So now you can use a drug. Just suffice it to tell you that it's an injectable drug. It's a monoclonal antibody that you inject twice a month into your leg. And what it does is that it reduces your LDL cholesterol by 60%. So nature has evolved PCSK9 for a specific purpose. So how many of you have heard about an acute phase reactant? When you get an infection, you get an acute phase reactant. So PCSK9 is an acute phase reactant. If you are under stress, the PCSK9 goes up so that the LDL receptors that suck up LDL from the circulation will go down, and more LDL is left in the circulation to fight infections, to provide energy delivery. So that's not important to study the PCSK9 functions for the industry. When you inhibit that agent or that molecule, you can reduce LDL cholesterol by 60%. So this is what happened. So this is the Fourier study, 28,000 patients, 14,000 were given the agent. The LDL cholesterol was 30 milligrams per deciliter over the period of the trial. In the control group, it was 90 milligrams. There were more deaths in the treatment group that got the PCSK9 inhibitor despite a 60% reduction in cholesterol, or the bad cholesterol. So I got this from Dr. Abramson, which says that dying with corrected cholesterol is not a successful outcome. I was expecting a laugh from that, but that's fine, it's late in the day. So what I want to say is that, should I trust the big pharma, the food industry, and go on a near processed vegan diet, take a statin, take a PCSK9 inhibitor to drive the bad cholesterol that the cardiologists like me like to do to near zero? Or should we take control of our own health through our own critical thinking? So that's what I tell my patients. Don't take my advice. I want you to take all this information and do critical thinking so that you can make your own decisions. So somebody asked me, I think there was a physician in the audience who asked me, do I prescribe PCSK9 do I prescribe statins and PCSK9 inhibitors? And my answer to that was that when I am writing a prescription, should I think about statins as mitochondrial toxins, as agents that alter cognition, that cause vascular calcification, that cause insulin resistance, that promote free radical injury, that damage your muscles, that misshape your mitochondrial DNA, especially when there is conflict of interest in industry-sponsored trials, and there is complete lack of checks and balances in these studies. So being a physician myself, I think that this is what we have done. I think we have abdicated our clinical responsibility to key opinion leaders, big pharma, food industry, various medical societies, and we are no longer thinking as clinicians. And we have to take some blame that we are perhaps the first or the second leading cause of death in the United States because of what we do. By that I don't mean, hey, don't go to the hospital if you break a bone or have a heart attack. When you come having a heart attack, I can put a stent and reduce heart muscle damage. But what I'm saying is that as clinicians, we have failed our patients as far as treatment of chronic diseases is concerned. We don't treat diabetes well, just like Dr. Volek has shown with his lifestyle intervention, much better than medications. We don't treat hypertension well. We don't treat fatty liver disease well. We don't treat dyslipidemia as well. So I think that it is highly important to do informed consent. When you're prescribing a statin, you should talk to the patients that there is potential toxicity, that there is inconsistent to absent benefit from all-cause mortality, that you're going to be using these drugs in these patients for 30 to 50 years, that there is conflict of interest, that there are lacks of checks and balances, and you should always make the patient aware of side effects, because I cannot tell you how many patients have come to me with severe myopathy in wheelchairs with a walker, not knowing that this could be a potential side effects of this drug. So at the end of this, I'm going to take a poll again, and what I'm saying is that should we celebrate or mourn a high LDL, because I think that through several of my talks that I have done before, high LDL is going to make you live longer, have lower cancer risks, have better cognitive ability, as long as you're practicing a low-carb diet, as long as you are reducing your insulin resistance, doing intermittent fasting, and meet the quality criteria. That is, your cholesterol quality is good, your HDL is high, your triglycerides are low, and your insulin levels are low. So that's all I had to tell you guys. Thank you.